Ladies and gentlemen, today I will talk about home blood pressure monitoring for clinical practice. I would like to start with this editorial we wrote more than 10 years ago, and it's saying about home blood pressure monitoring, it's time to take this method seriously. This is because if we take serious, careful measurements of blood pressure in the office and out of the office, we used here ambulatory monitoring and home blood pressure monitoring, you'll find that there are several people with diagnostic disagreement, white coat or mass hypertension among untreated subjects. But also if you go to treated individuals, again, a considerable number of individuals have white coat and mass hypertension, either using ambulatory or home monitoring. And these diagnoses are clinically relevant. These are data based on more than 60,000 people followed for longer than 8 years with office and home measurements. And you can see among both untreated and treated people, those with white coat or mass hypertension, white coat phenomenon have similar risk to normotensive people. But however, if you look at the mass hypertension phenomenon, in untreated people, it has similar risk to uncontrolled hypertension, but in treated people, mass hypertension have even higher cardiovascular risk than uncontrolled hypertensives. And if you have the ability to follow people for a long time, as we did here for 20 years in the Didima study in Greece, you can see that in the long term, only normotensives do well in terms of total mortality and cardiovascular disease. All phenotypes, white coat, muscle sustained, in the long term, they are associated with increased risk. This is a provocative editorial we published several years ago, saying that if you have good home measurements, then maybe office blood pressure measurements become obsolete. This is because we looked at two different meta-analyses comparing the prognostic ability of home versus office measurements, and we saw that home measurements in both meta-analyses appear to have superior prognostic ability. However, these people did an interesting additional analysis. When they adjusted office measurements for home blood pressure, office measurements did not have many prognostic ability. But when they adjusted home measurements for office measurements, then home measurements retained their prognostic ability. I'd like to show you here a study where we compared office, home, and ambulatory measurements for treatment initiation and titration. And we had two groups. One group used two methods, regular office measurements and also occasional use of 24-hour ambulatory monitoring. The control group used one method alone, home blood pressure monitoring, and the endpoints were target organ damage and blood pressure control. And after longer than a year of follow-up, you can see here the two groups, office and ambulatory versus home alone. No difference in blood pressure changes, systolic and diastolic. No difference in blood pressure control. No difference between groups in organ damage regression at the level of the heart, the kidneys, and the arteries. But there is another aspect of home blood pressure which is important because patients seem to prefer home blood pressure monitoring. And I'm comparing here data from two countries. And these are different countries because home blood pressure monitoring is very widely used in Greece for several decades, but not for UK. UK only in the last years have started using home measurements. And these two countries with different use of home measurements bring the same message. You can see in the UK study, 80% of patients preferred home blood pressure, and they found it more comfortable and easy to use. And in the study in Greece, it was easier for the patients to perform a home monitoring than ambulatory monitoring, and they preferred this method for their repeated assessment. Another unique advantage of home monitoring is that it has been shown to improve long-term adherence with treatment and thereby hypertension control. And you can see here a systematic review meta-analysis of 25 randomized controlled trials and showed the small yet significant overall effect in improving medication adherence of patients treated for hypertension. And for those of you who are more interested about the cost, which of course is important, this is a cost estimation of the study I showed where we compared home blood pressure alone versus ambulatory and office together. And you can see here in year one, both measures were expensive. First, because home blood pressure, you had to get a new device, and ABPM had to be used repeatedly for treatment titration and decrease the cost. So little difference, and both methods expensive here. But in year one, there was a little advantage of home measurements compared to ambulatory monitoring. And in the long term, 5 years, there are considerable benefits in terms of cost when using home blood pressure alone. And I think Tom Pickering was right several years ago when he called to act and reimburse home blood pressure monitoring for hypertensive patients, as we do with glucose monitors for patients with diabetes. And he rightly said that this method has the potential to improve the quality of care and also reduce the cost of care of these people. But home blood pressure measurement has a weak point, and this is the reporting bias. It has been shown that patients select which readings they are going to show to their patients. They usually discard the higher readings. Ladies and gentlemen, you cannot rely, we cannot rely to such reports of home measurements to base decisions using home measurements. But there is ability to eliminate this bias with modern technology. Electronic devices with automated memory and PC mobile link can give an objective picture of the blood pressure level at home. And home blood pressure telemonitoring is a 21st century solution for hypertension. There are several devices, low-cost devices, with ability to connect with your mobile to provide graphs and averages of long-term home blood pressure monitoring and put all this data instantly in your mobile, in your pocket. And this is the Tasmin project by Professor Richard McManus in UK, where he showed in primary care in UK that home blood pressure telemonitoring leads to significant lower blood pressure than treatment titration guided by traditional clinic readings, and concluded that home blood pressure can become the cornerstone of hypertension management. Home blood pressure can be valuable for clinical research in hypertension. Let's say that you want to compare the antihypertensive effect of two drugs, and you aim to identify a treatment effect with the two drugs at least 5 millimeters mercury. And you wish to have a study power of 80% in your study, which means 80% chance to find a real difference if it exists. And you can see here the power curve. If you use clinic measurements, the power is something like 65%. And here's the power curve. If you use 24-hour ambulatory monitoring, it goes to 87%. And even better if you use home measurements, 90%. Which means that using out of office measurements, ambulatory and also home, you can increase the power of antihypertensive drug trials. Another interesting aspect is that home blood pressure monitoring is useful for assessing the duration of action of antihypertensive drug treatment. You know that we use the trough to peak ratio with ambulatory monitoring, and this is a study where we used home and ambulatory monitoring to assess the duration of action of antihypertensive treatment several years ago. And we used the trough to peak with ABPM and the morning to evening ratio with home measurements. And you can see in this study where compared losartan 50 versus lisinopril 20, trough to peak ratio showed that the duration of the effect of lisinopril was longer, but also home blood pressure monitoring morning evening ratio again was able to demonstrate the longer duration of blood pressure lowering effect of lisinopril compared to losartan. But ambulatory monitoring has a unique advantage, and this is the 24-hour blood pressure curve, and ABPM is regarded as a unique tool to assess nighttime blood pressure and dip. However, this is not the case anymore because there are several devices, home devices, that can be used during the night for 2 or 3 days and take 3 readings every night and can detect non-dippers. Here is a study where we compared an ambulatory monitor, 24-hour ABPM, and also a home monitor with a software able to take nighttime readings during sleep. And you can see daytime, nighttime blood pressure was similar, and there was agreement between the two methods, ambulatory and home, in detecting in non-dippers at about 74%. I remind you here that even if you do ABPM twice, the reproducibility of the method is about 70%, which means the agreement between the two methods is excellent. And these are data from 3 countries, from Japan, from Greece, and from Finland. And these studies looked at the association of nighttime blood pressure identified by home monitors or identified by classic ABPM versus organ damage, left ventricular ascites, and you can see they're quite similar. So it seems that nighttime blood pressure detected by home monitors has similar ability to see organ damage as conventional ambulatory monitoring. Now, moving to the last part of my talk, let's focus on the guidelines, how to use this method today in clinical practice. And I think the American guidelines in 2017 made an outstanding recommendation and said that out-of-office blood pressure, ambulatory or home, should be used first to confirm the diagnosis of hypertension. Second, whenever treatment titration is to be decided. This means that the decision to start treatment, to titrate treatment, are moved out of the office with out-of-office measurements, ambulatory or home. And they made this recommendation for both untreated and treated individuals. They specifically said that if office blood pressure is between 120 to 160 and diastolic 80 to 100, which is the vast majority of people seeing our clinic, then you can't make a diagnosis in the office. The office blood pressure does not have the diagnostic accuracy to make a reliable diagnosis within this range of blood pressure. And then you need ambulatory or home measurements. And the European guidelines had the same philosophy in using blood pressure measurements. And they said, if blood pressure is lower than the hypertension threshold, it is within the high normal threshold, you are not done, you are not finished. You need to do out-of-office measurements, ambulatory or home, to consider potential mass hypertension. But even if your office blood pressure is higher than the threshold, then again, you need out-of-office measurements because of the potential of white coat phenomenon. I think it is important to say here that both methods can be used for detecting white coat and mass hypertension, but ABPM is maybe more appropriate for initial diagnosis. You have the answer in 24 hours. It is unbiased, and you don't need to train the patients. However, home monitoring is more appropriate for the long-term follow-up of treated hypertension because it is more widely available. It is well accepted by patients for repeated use and has been shown to improve treatment compliance from the long term. But there are barriers for using this method, and these are data from the United States saying that the more important barriers are that doctors have concerns about how correctly patients make measurements. There are concerns that patients may become preoccupied with blood pressure. They may take too frequent measurements. They may change treatment on the basis of individual home readings. And there are issues with device affordability in some populations. I would add here, and also with devices accuracy. But another important point from this paper is that healthcare providers may lack confidence in their skills and knowledge to interpret HBPM. So it's important to spread the message how to use home blood pressure monitoring efficiently in clinical practice. And I'm close to the end, and I'd like to present here practice guidelines that the European Society of Hypertension published a few weeks ago, showing how these methods should be used in primary care. For the indications, you can see there are two groups of indications, a small group for initial diagnosis and a big group for treated hypertension. For initial diagnosis, home blood pressure monitoring is useful to confirm diagnosis and to detect wide coronary mass hypertension. However, in treated hypertension, the recommendation is too strong. It is recommended to be used in all treated hypertensives unless they are incapable or unwilling to perform home monitoring in good quality or anxious with self-monitoring. They are recommended to identify wide coronary mass hypertension phenomena, to titrate treatment, to monitor long-term control, and to improve long-term compliance of patients with treatment. For the devices, the European Society of Hypertension recommends electronic upper arm cuff devices which have been properly validated. It is preferred to use devices with automated storage and averaging, or mobile phone, PC, or internet connectivity for objective reporting of measurements. Wrist devices, auscultatory devices, wristband wearable cuffless devices are not recommended for home monitoring. It is very important that there is now a universal protocol, one protocol around the world for validating blood pressure monitors, all monitors. And if you want to find which devices on the market are validated, you should visit one of the established websites. The STRIDE-BP is supported by the European Society of Hypertension, the International Society of Hypertension, and the World Hypertension League. It is important to say here that only 8% of the blood pressure devices available on the market are approved by the STRIDE-BP. So you go to this website and you download the list, updated list on accurate home monitors or office monitors or ambulatory or lists for children and pregnancy. Only validated devices should be used. For home measurements interpretation, as I said, we prefer automated report and averaging. Otherwise, if these devices are not available, you can use a logbook. It is recommended to take same days home monitoring, but no less than 3 days with no fewer than 12 readings. The first day is usually higher and unstable and should better be discarded, particularly if you have few days monitoring, and the average of the other days should be calculated. Individual readings, high or low, have very little diagnostic accuracy, and the average of home measurements should be lower than 135 over 85. And this is the piece of paper we give to our patients to record the home measurements for 7 days before their visit to the doctor. Before each visit, they should prepare this schedule of home measurements. It is important to show here these recommendations For the long-term follow-up between office visits, we recommend duplicate measurements once or twice per week or month, depends on the patient's preference. So anybody interested on these practice guidelines for blood pressure measurement, this paper published in the Journal of Hypertension a few weeks ago, it is available for free download. And you can find here a single page with all the practical information for the practicing doctor to use home blood pressure monitoring in clinical practice. There is another single page for instructions for ABPM and one more, a third one for office measurements. Ladies and gentlemen, home blood pressure monitoring should be the primary method for diagnosing and following hypertension clinical practice. It's time to take this method seriously. Thank you.
Thank you very much. This was very informative and very useful information. Unfortunately, in many developing countries like Egypt and many other countries, this may not be an easy job for a number of reasons. The availability of these equipments is limited. Their accuracy, we are not sure about it. And I'm sure that the majority of our patients will not afford it. And how reliable are the measurements obtained? And it seems that we need some time before introducing this technique to our country.
If I could answer to that, can you hear me?
Yes, I can hear you very well.
I think this is a very important comment we should take into account. I think I have two issues to comment on that. One is that accurate devices can have cost lower than 50 to 40 euros and can last for 1 decade. And the second is we have to consider that home blood pressure can save costly treatment by diagnosing white coat effect. So if you combine the low cost of accurate devices, the long life they have, and their potential to save treatment costs of drugs for a long time, I think all these should be taken in consideration, and it is important to base decision as much as possible in home measurements. But I certainly fully agree that in your country and in my country and in every country, several people will never have out-of-office measurements, and we have to base decision on careful office measurements.
Thank you.
Thank you very much for your elegant presentation. My question is, can we rely on automated wrist device for follow-up for a long period of time?
You mentioned wrist devices, not arm devices.
Yes, wrist device.
So if we are talking about wrist devices, these devices are two types. One is the wrist cuff devices. So they have a cuff that inflates as much as the arm devices. And we also have the cuffless devices without the cuff. For the wrist cuff devices, some of them have been validated and are regarded to be accurate, but we tend to prefer arm devices because they have two advantages. One is that they are more accurate in general than wrist devices, and the second is that the wrist devices have issues with the correct use of the position of the wrist by the patients and so on. So these can be accurate, the cuff-based wrist devices, but we prefer arm devices. For cuffless devices, the 2021 ESA guidelines do not recommend cuffless devices. Cuffless devices have great potential. They are very attractive, but they have different accuracy issues, and we still do not have a proper procedure to validate them. So they are promising. We hope manufacturers will come with better solutions. For the moment, we don't recommend them for decision, diagnostic, or treatment.
Thank you very much.
Thank you for this lecture. I would like to ask you if about the suitability of this use for the using of this device in our country, in spite of it need more information for patient and more stability of psychologically of patient.
Yes, you are right. There are two things here. One is you need to train the patient how to use the device. So the physician needs to spend time and train the patient how to properly use it. Most of the patients under medical supervision will do very well, will give you accurate measurements. Some patients are nervous and anxious with self-measurement, and this may be better not to use home measurements. But most of the patients under medical supervision provide very accurate measurements. I have also to tell you that in my clinic, we have a model where we have home monitors. These are very low cost, 50 euros. Ambulatory monitors cost more than 600 or 700 euros. So we have home monitors, which we give to patients for 5 days, which is much less expensive than using ambulatory monitoring.
Thank you very much for informative talk.
Thank you.